All right, so let's start with the female reproductive system. The primary reproductive organs in the female are going to be the ovaries, because remember I said when we use the term primary reproductive organs, you're referring to the gonads, and the gonads in the female are going to be the ovaries. Accessory reproductive organs include the uterine tubes, otherwise known as the fallopian tubes, uterus, vagina, clitoris, and the mammary glands. All right, so let's look at the anatomy of the ovaries. The ovaries are paired oval structure, roughly the size of an almond, size and shape of an almond, I should say, and they sit lateral to the uterus. So here's your uterus here, and out here are your ovaries. There's one, and there's two. If you section an ovary and look at it microscopically, so if you took this view, you would see that the ovary has this kind of thin epithelial layer called the germinal epithelium. That's over here. And then deep to the germinal epithelium is a connective tissue capsule called the tunica albuginea. Deep to the tunica albuginea, then you've got the ovary partitioned into the cortex and the medulla, where the cortex has the ovarian follicles. So all of this area would be the cortex, and then the medulla, as usual, has some blood vessels, lymphatic vessels, and then nerves. Within the cortex of the ovary, you've got thousands of ovarian follicles. Ovarian follicles consist of an oocyte here, surrounded by follicle cells. Sometimes you'll hear follicular cells or granulosa cells. All these cells right here that support the oocyte. There's several different types of ovarian follicles, with each one representing a different stage of development. So primordial follicles are the more primitive type. You're going to have most of the follicles are going to be in this stage. And then every month only a few of those primordial follicles will develop into a primary follicle. And then from the primary follicle, it would develop into a secondary follicle. From there, it goes on to a vesicular follicle. After ovulation, it becomes a corpus luteum. And then a while after that, it becomes a corpus albicans. So these are kind of the various stages of follicles. Once like the monthly ovarian cycle starts, you'll see development of the primary, secondary, vesicular, corpus luteum, and corpus albicans. But most of them are kind of in this primordial follicle stage. So like I said, the primordial follicle is the most primitive type of ovarian follicle. Each one consists of a primary oocyte surrounded by a single layer of flattened follicle cells. So you can see that in this image right here. It's a primary oocyte, and then you've got a thin single layer of flattened follicle cells surrounding it. Now what a primary oocyte is it's an oocyte that's arrested in the first meiotic prophase. So we have about 1.5 million of these types present in the ovaries at birth. After the primordial follicle, you'll get development into a primary follicle. Okay, each primary follicle consists of the primary oocyte again, but now you have one or more layer of these cuboidal follicular cells. These are now called granulosa cells. So here's your here's your primary oocyte, and then you've got these different layers of granular cells. On the outside of the granular cells, you'll notice the thecal cells. This lighter color cell that's kind of surrounding the whole thing, those are called thecal cells, and then granulosa cells inside, and then your oocyte. Each primary follicle secretes estrogen as it continues to mature. The estrogen is going to stimulate changes in the uterine lining. So we're going to get development of a primordial follicle into a primary follicle. You can see the cellular layer around it begins to grow. And from there, you're going to get release of estrogen, which is going to do a couple different things. It's going to promote the continual development of this follicle. It's also going to stimulate the uterine lining. So from the primary follicle, you get development of the secondary follicle. Secondary follicle contains the primary oocyte, many layers of those granulosa cells that are in here, and you start to get the creation of this fluid-filled antrum, which is just the space inside the follicle that's filled with fluid. So this is serous fluid that's accumulating in here, and it continues to increase in volume as you get closer towards ovulation, and it kind of pushes the oocyte towards one side of the follicle. So you'll notice if you compare this to the vesicular follicle below it, you can see the oocyte is no longer in the center, but rather over to the side. So that's what this is doing. You're getting the creation of this fluid-filled space, or the antrum, and then it kind of forces the oocyte to one side of the follicle. Okay, so from the secondary follicle, you get the vesicular follicle. This is also sometimes called a Graafian follicle or a mature follicle, so you can see it right here. The vesicular follicle becomes very large. At this point, it contains a secondary oocyte. So the secondary oocyte is, so remember the first, the primary oocyte was arrested in meiosis. The secondary has completed meiosis 1, and now it gets arrested in the second part of meiosis, in the meiotic metaphase phase. So you've got your secondary oocyte here in the vesicular follicle. It's got a bunch of the granulosa cells, and then a very large fluid-filled antrum. So that's kind of how you can tell the vesicular follicle, because it's got the largest of this fluid-filled area, the antrum. And then again, your oocyte, your secondary oocyte, is over here towards one side of the follicle. Typically, you're only going to get one vesicular follicle each month. So basically the way it happens is each month a few of the primordial follicles will start to develop, and then they'll move on to the primary stage, and some of those primaries will die off, and you can end up with, like, one or maybe two secondary follicles that continue to develop. But typically by the time you get to the vesicular follicle, only one of those. So out of the handful of primordial follicles that started to develop that month, you'll only get one that typically would develop into a vesicular follicle. And you can see this, you can follow this in the ovary section they have here. These are primordials developing into primary follicles, developing into secondary follicle, developing into a vesicular follicle, and notice the next thing that happens here is the rupture, which is ovulation. So here, this was your vesicular follicle right here. Ovulation occurs, which is basically the rupture of that vesicular follicle, and as it ruptures, the oocyte is allowed to leave the ovary. So while the oocyte leaves, you still have all of this follicle that's left. And so the next stage is what happens to the remaining follicle, and that's called the corpus luteum. Corpus luteum literally translates to yellow body, and you'll notice it's kind of a yellowish structure. The corpus luteum secretes sex hormones, mostly progesterone, but also estrogen. And then those hormones stimulate and support the continuing buildup of the uterine lining. So what we're doing is we're trying to, because we're over here in the ovaries, we're not looking at the uterus, but we're nurturing and developing an oocyte with the hopes that after it ruptures, it might find its way to a sperm in the fallopian tube, in the uterine tube. Now, if it does that, we can only do anything with it if we have a thick vascularized uterine lining for it to implant. So the hormones that are getting secreted from the follicle, and then again from the corpus luteum, while one of the roles of those hormones is to continue the development of the follicle and such, the other role is to stimulate and vascularize the uterine lining, so that if this oocyte does find a sperm and it gets fertilized, there's a nice thick vascular structure for it to implant in. Okay, so the Corpus luteum mostly releases progesterone, and that mostly vascularizes. So there's a lot of overlap between estrogen and progesterone. But I tend to think of it in order to kind of reduce some of that overlap and keep it simple. You're secreting a lot of estrogen as you're moving through the follicles. Estrogen stimulates and builds the uterine lining. After ovulation, when you get to the corpus luteum, now you start to release more progesterone, and progesterone vascularizes it. Okay? Now again, it's not that cut and dry. There, you've got some overlap there, but that's kind of a simple way to kind of look at it. Okay, so eventually the corpus luteum will degenerate into this white structure called a corpus albicans. A corpus albicans is basically scar tissue. So what's going to happen is this corpus luteum, what it's doing, and we touch on this in a little bit again, but this is releasing progesterone. This is maintaining the uterine lining long enough for the placenta to take over. So it's basically saying, I really hope that this oocyte gets fertilized and it implants, and then eventually a placenta will take over hormone production. So I'm going to do the job in the meantime. Now, if implantation does not occur, then it does no good to just stay around and continue to release hormones. So if no fertilization, no implantation occurs, this corpus albicans will degenerate into the corpus luteum will degenerate into the corpus albicans, and the corpus albicans does not release hormones. It's just a scar tissue structure, and they're actually still visible a lot of times on the ovary, but it doesn't release hormones. So at that point, the hormone release would stop, everything calms down, and then you can start the cycle all over again. So this is kind of, we're describing the ovarian cycle in this case. So here is everything up close again. You've got the primordial follicles developing into primary follicles. You've got the granulosa cells. Here you can see granulosa cells, and then the thecal cells kind of on the outer edge. Developing into a secondary follicle where you start to see the accumulation of fluid in there. Vesicular follicle where you have this large crescent fluid-shaped antrum, forces the now secondary oocyte over to the side. You can see it almost causing the bulging in the side of the ovary. And then eventually out of the vesicular follicle ruptures the oocyte. That's ovulation, when it actually bursts out of the follicle. All of the time that this was developing, it's releasing estrogen. It is stimulating the buildup of the uterine lining. When the oocyte gets released, it's going to enter into the uterine tubes, and we have follicular cells here that are going to degenerate into what's called a corpus luteum. Corpus luteum releases progesterone to maintain that uterine lining for some time, and then if fertilization and implantation does not occur, this will degenerate into corpus albicans, which is scar tissue, and then hormone release stops, and then eventually you can start again. So this is just a chart kind of talking about the structure of the follicle, what type of oocyte is in it, whether it's a primary oocyte, a secondary oocyte, or in the case of the corpus luteum and corpus albicans, there's no oocyte because these are formed after ovulation takes place. Kind of the description of the structure and when you first see it. So primordial follicles actually develop during the fetal period. So female babies are actually born with their primordial follicles, but they're arrested in that meiosis 1. So they're there, but nothing happens to them. In fact, they actually start to die off, but they don't develop or mature until puberty. Okay. The term oogenesis refers to the maturation of the primary oocyte into that secondary oocyte. So the process of oogenesis actually begins in the female fetus before birth. At that time, the ovary contains what are called primordial germ cells, and they're called oogonia. Oogonia are diploid cells, so they've got the 23 pairs of chromosomes, or 46 total. Okay, so that's kind of your starting point for the formation of oocytes, are these diploid oogonia cells. During the fetal period, the oogonia divide by mitosis to produce primary oocytes, and then the primary oocytes are the structures that are actually going to enter into the process of meiosis, except that they get arrested in prophase 1. So at birth, the ovaries of the female child are estimated to contain about 1.5 million of those primordial follicles within the cortex, all containing a primary oocyte. And then the primary oocytes in those follicles stay arrested in prophase 1 until the time that puberty starts. So between the fetal period and puberty is, of course, going to be childhood. So during childhood, the female's ovaries are going to be inactive, so there's no developing follicles at that point. In fact, what's actually going to happen are a bunch of those follicles are actually going to regress. That's called atresia, so it's kind of like they're dying off. So where they had 1.5 million in the fetal period, by the time they reach puberty, they only actually have about 400,000 primordial follicles remaining in the ovaries. Now, once that child reaches puberty, that's when the hypothalamus is going to start to release that gonadotropin-releasing hormone, or the GnRH, and it's going to do so in a pulsatile manner. So the GnRH from the hypothalamus is going to act on the anterior pituitary and stimulate it to release follicle-stimulating hormone, or FSH, and luteinizing hormone, or LH. So the levels of FSH and LH are going to kind of vary in this cyclical pattern, and it's going to produce this monthly sequence of events that's going to lead to the follicular development, and we call that the ovarian cycle. So we have kind of looked at this when we looked at how the oocyte in the follicle evolves from the primordial follicle to the primary, secondary, vesicular, and then we saw how the oocyte got ovulated. It sort of ruptured out of the follicle. We went to the corpus luteum and the corpus albicans. So in those ovary slides. So we've at least seen how it kind of evolves, and that's basically the ovarian cycle. So we're just going to kind of look at that now, but within the context of the hormonal changes as well. So the ovarian cycle happens in 3 phases. You've got the follicular phase, and then ovulation, and the luteal phase. So follicular phase is everything before ovulation. Ovulation is the rupture of the follicle where you get the release of the oocyte, and everything after ovulation is the luteal phase. Keep in mind, we're not talking about the menstrual cycle. The menstrual cycle happens as a result of changes that are happening in the uterus. The two are very interconnected. You've got changes in the ovaries, you've got changes in the uterus, and they're all changing based on the same changes that you see based on hormones. But right now we're specifically looking at what's happening in the ovary. Okay, and one last thing before I switch slides. We're still talking about sort of oogenesis, or what's going on with the oocytes. We looked at it in the fetus and then during childhood. And so the next few slides we're still on the same topic, but now we're just simply describing the changes that are going to happen on a monthly basis during the time frame between puberty and menopause. Okay, and then we'll finish oogenesis with basically what happens after menopause. So looking at the follicular phase occurs during days 1 through 13 of an approximate 28-day ovarian cycle. At the beginning of the follicular phase, you have FSH, which came from the anterior pituitary, and it's going to stimulate a handful of primordial follicles to start developing and maturing into those primary follicles. So roughly 20 primordial follicles will kind of come out of their sleepy state and start to develop into these primary follicles. Okay? As the follicles develop, those follicular cells that surround them start to release a hormone called inhibin. Inhibin inhibits further FSH production. So once we kind of arouse some of those primordial follicles to start developing, we want to slow down the FSH production. Otherwise, FSH, like its name suggests, follicle stimulating hormone, it'll just keep on stimulating all those primordial follicles, and then, eventually we run out. So once we kind of get a few of those up and running and kind of turning them from primordial into primary follicles, they start to release inhibin, and inhibin kind of quiets down or lessens the level of FSH that gets released, okay? Okay, so shortly after that, you get a few of those primary follicles are going to continue to mature into a secondary follicles. The primary follicles that don't mature onto secondary just undergo atresia. So you got a handful of primordial follicles that become primary, and then some of the primary follicles, in fact, a lot of the primary follicles end up undergoing atresia. They kind of die off. Just a couple of those will continue on to become secondary follicles. And then later in the follicular phase, typically only about one secondary follicle will continue to mature into a vesicular follicle. Under the influence of luteinizing hormone, the volume of the fluid increases within the antrum of that follicle, and the oocyte gets forced to one side of the follicle. So we saw that when we looked at the ovary slide. So it was in the secondary follicle where you start to see the buildup of fluid in there. That's called your fluid-filled antrum. But one of the main differences between that secondary follicle and the vesicular follicle was the volume of fluid that's in there. You see a little bit of fluid in the secondary follicle, but luteinizing hormone actually causes that serous fluid to continue to build up, which kind of causes it to transition into the vesicular follicle, which has a really large volume of fluid in its antrum, and it takes on that C or crescent shape. Okay, and as a result of all that fluid buildup, it shoves the oocyte over to one side of the follicle. As the secondary follicle matures into the vesicular follicle, the primary oocyte finishes meiosis 1. It forms 2 cells, but one of those cells only receives a very minimal amount of cytoplasm, and it forms what's called a polar body, which is a non-functional cell, so it later basically dies off and regresses. The other cell receives the bulk of the cytoplasm, so that is then your secondary oocyte, which will continue to develop. Okay, so remember it was the oocyte was a primary oocyte originally, and which is arrested in meiosis 1. So as it kind of transitions from secondary follicle to the vesicular follicle, it quickly finishes meiosis 1, it enters meiosis 2, but it doesn't quite do a good job of splitting the cells evenly. Basically, the 2 cells that would be the result of meiosis 1, only one of those cells receives the majority of the cytoplasm. The other one dies off. So we end up just kind of with 1 cell there. And that, at that point, is the secondary oocyte. Ovulation is the next stage, and it is on approximately day 14 of a 28-day ovarian cycle. And this is where the oocyte's actually going to get released from the follicle. So at this point, it's a secondary oocyte. It's getting released from the vesicular follicle, otherwise known as the Graafian follicle. And each ovary tends to alternate each month. So the right ovary will ovulate 1 month, and then the next month it's the left, and then it just kind of goes back and forth. Now, what actually causes ovulation to happen is there's this really rapid surge in luteinizing hormone release, or LH secretion. So you get, it's called the LH surge. You get this sudden peak of luteinizing hormone that comes out. And what that does is it causes the rate of this fluid buildup inside the antrum to increase. And so you get this more and more and more fluid being accumulated in that antrum, and it's shoving that oocyte way off to the side until the point where it basically just ruptures. And then out comes the oocyte, and it's, again, going to get picked up by the uterine tube. So it's basically just this rapid onset of luteinizing hormone that causes the fluid buildup to increase its rate, and we eventually get so much fluid that it kind of forces the oocyte out of that So So the oocyte has left now. It is out of the ovary, it's in the uterine tube, but we're actually going to stay in the ovary and look at what's going to continue to happen. So what we had was that vesicular follicle or Graafian follicle with the oocyte in it. Oocyte has left during ovulation. So everything after ovulation is called the luteal phase, and basically the remnants of that follicle are going to become what's called the corpus luteum. Okay, so luteal phase is going to be between days 15 to 28 of the ovarian cycle. The remnants of the vesicular follicle become the corpus luteum, which is essentially a temporary endocrine gland. It's going to release mostly progesterone, and that's going to stabilize and build up the uterine lining to prepare for possible implantation. So we want to have a thick and vascularized uterine lining so that if the oocyte finds a sperm and gets fertilized in the uterine tube, it's got a nice place in the uterus for implantation. So the corpus luteum has a lifespan of about 10 to 13 days. If the secondary oocyte does not get fertilized, after that point the corpus luteum just kind of regresses and it turns into that scar tissue structure called the corpus albicans. The corpus albicans does not continue to release hormones. So once the corpus luteum degenerates into the corpus albicans, hormone release from the ovary stops. As the corpus luteum again starts to regress, the levels of progesterone and estrogen will go down because it was coming from the corpus luteum, and that's what was maintaining the uterine lining was the release of those hormones. So as they start to go down, what's going to happen? There's nothing to maintain the uterine lining, so the uterine lining is going to be shed, and that's what we call menstruation. So menstruation marks the end of the luteal phase. A female's first menstrual cycle is called menarche, and typically happens around the age of 11 to 12, but there's a lot of variation in that age. Okay, so that is happening, what we just talked about was happening on a 28-day, roughly 28-day cycle, all the way from puberty to menopause. Okay, and here's what happens when we get to menopause. So once a woman has stopped having a monthly menstrual cycle for 1 year and she's not pregnant, she is said to be in menopause. Menopause can happen anywhere between 45 and 55 years of age, give or take. And the reason a woman reaches menopause is either because there's no more ovarian follicles, so there's no more follicles remaining in the ovaries to develop, or because the follicles that were already there just basically stop developing. Okay, so we saw that as the follicles developed in the ovary, what did they release? They released hormones. They released estrogen and progesterone, and those hormones are what's responsible for building and vascularizing the uterine lining. So if we do not have follicles developing, then we don't have those hormones being released. And that means the uterine lining is not going to grow and thicken and become vascularized. And so that's why she's no longer going to have a menstrual period, because she's just not getting the hormone release, so she's not getting the uterine lining buildup. So y'all know I always like to try to provide these kind of complex ideas in a couple of different ways, because some people like to just straight up read it step by step by step and get it in their head that way. Other people benefit more from a diagram, or a picture or something. So the next few slides, so this one and the next one are basically the text version, and then I've got the diagram version after that. So if you are reading through this and it's just too much and you're like, I don't like these slides, it's okay. Just kind of skip ahead to the diagram and you'll basically get all of the information in the diagram. I think the only thing that's included in this slide and the next talks about the intervention of hormonal contraception, birth control, that is not in that diagram. So kind of look through that. But basically it's two versions of presenting the same material. So what we're looking at is the hormonal regulation of the ovarian cycle. So how those hormones are fluctuating as we're going through that ovarian cycle that we just talked about. So again, it starts with the hypothalamus. The hypothalamus initiates the whole process by releasing gonadotropin-releasing hormone, or GnRH. GnRH stimulates the anterior pituitary to release FSH and LH. FSH and LH go down and they target the ovaries and they stimulate the initiation of follicular development. Specifically, FSH really starts the follicular development. So the follicles start to mature, and as they start to mature, they start to release hormones of their own. They start to release inhibin, and they also start to release estrogen. Those hormones have a negative feedback effect on the hypothalamus and the anterior pituitary. So inhibin is going to go back, and it's going to inhibit FSH release. So we don't get too much FSH release by the anterior pituitary. Low levels of estrogen, mind you, low levels, they inhibit the production of GnRH, FSH, and LH. So we started in the brain, and then we communicated with the ovaries, and now the ovaries are releasing their own hormones, which are kind of communicating back to the brain to kind of turn down those initial signals. So estrogen also assists with the development of the dominant or the vesicular ovarian follicle. So as estrogen is getting released from those earlier stage follicles, it's kind of promoting the transition of its own self towards that vesicular follicle. So you got the primary would go in to become a secondary, and then the secondary goes in to become the vesicular follicle, all under the influence of the estrogen that follicle is releasing. So the vesicular follicle, it develops a whole bunch of cells around it. And what that does is all of those cells are releasing estrogen. So the more cells it builds upon itself, the more estrogen it releases. So it's a little bit of a paradox here, because remember I just said low levels of estrogen inhibit GnRH, FSH, and LH. Well, now we're in the vesicular follicle, we have a lot of cells, and so we get this really high level of estrogen. And now the higher levels of estrogen actually have a stimulatory effect on the hypothalamus and anterior pituitary, and so we end up getting a positive feedback loop. So it's kind of this weird thing where we had a negative feedback, but by the time you get to the vesicular follicle, now we're dealing with a positive feedback loop. So what that positive feedback looks like is you had the increasing vesicular follicle, and it's releasing higher amounts of estrogen, and that estrogen then stimulates the release of this rapid surge in luteinizing hormone. So you get this really quick, really high release of luteinizing hormone. That luteinizing hormone acts on the vesicular follicle to rapidly increase the amount of fluid that's coming into that fluid-filled antrum, and that essentially shoves the oocyte out of that vesicle, and that's ovulation. So this is the point in time that oral contraceptives work to regulate. So they try to keep that estrogen level very steady so it doesn't ever reach levels that are high enough to induce the LH surge. That way we never get ovulation. Okay, so after ovulation, you still have the luteinizing hormone around, and that luteinizing hormone stimulates the transition of the remnants of that vesicular follicle into the corpus luteum. And so then the corpus luteum starts to release large amounts of estrogen, progesterone, and inhibin. All three of those hormones work at the brain to negatively feedback for luteinizing hormone and FSH. So all three of those hormones tell the brain to chill out on releasing FSH and LH. In addition, the estrogen and progesterone are also communicating with the uterus, telling it to continue to build and vascularize its lining. Now, if no pregnancy happens after 10 to 13 days, then that corpus luteum will degenerate into the corpus albicans, which is a scar tissue structure. And because it's a scar tissue structure, it doesn't release hormones. So after the corpus luteum degenerates into that, hormone levels will drop. Now remember that the hormones that were coming from the corpus luteum were acting as negative feedback regulators for the brain. So it was those hormones that's responsible for the brain not releasing FSH and LH. When the corpus luteum becomes the corpus albicans and those hormones go down, we lose that negative feedback. And now the brain is able to start releasing gonadotropin releasing hormone and FSH and LH all over again and start a new cycle. So let's look at it all again in this picture so we can kind of see all the parts and pieces. So starting at the hypothalamus, you have GnRH, gonadotropin releasing hormone. It's talking to the anterior pituitary. Anterior pituitary is going to release FSH and LH. Those two hormones go down to the ovary and stimulate the maturation of the follicles. So here we have a maturing follicle. It is starting to release estrogen and inhibin. Estrogen and inhibin have a negative feedback effect on both the anterior pituitary and the hypothalamus. So as this follicle matures, it releases estrogen and inhibin, which kind of tells the hypothalamus and the anterior pituitary to stop releasing so much FSH and LH. It also, that estrogen that's coming from this follicle also promotes its own development. So it's basically telling itself to keep growing larger and larger. And so eventually we'll get to this large vesicular follicle. See how the oocyte is already shoved to one side? You've got this large fluid-filled antrum. And now you have lots of cells that are releasing estrogen. So you end up getting a large amount of estrogen being produced. And this is where we switch from estrogen being a negative regulator to a positive regulator. So when you have large levels of estrogen, you have a positive feedback effect on the brain, and it causes the anterior pituitary to release a large surge of luteinizing hormone. So now you have a lot of luteinizing hormone coming out of the anterior pituitary that causes the super rapid filling of this fluid-filled space, and eventually it gets so full it ruptures the follicle, and now the oocyte escapes the follicle, and that's ovulation. So now the oocyte is going to continue on to the uterine tubes. Here's the remaining components of the vesicular follicle, and under the influence of luteinizing hormone, that is going to become the corpus luteum. So here's the corpus luteum. The corpus luteum secretes large amounts of progesterone, estrogen, and inhibin. Okay, so all of those inhibit, again, the hypothalamus and the anterior pituitary, so we slow down again the production of FSH and LH. Estrogen and progesterone are also having effects on the uterus, where they're continuing to build the uterine lining. So estrogen and progesterone are doing double duty here. They're having negative feedback effects on the hypothalamus and the anterior pituitary. They're having stimulatory effects on the tissue lining of the uterine wall. Okay, and then if the body doesn't receive any signals of pregnancy, then 10 to 13 days later, the corpus luteum will degenerate into a corpus albicans. So keep this in mind. The estrogen and progesterone that are coming out, in addition to the inhibin, that are coming out of the corpus luteum, they are negatively feeding back on the hypothalamus and anterior pituitary. They're telling the brain, do not release any more FSH and LH. When no pregnancy comes about, and the corpus luteum generates into the corpus albicans, there's no hormones coming out of the corpus albicans. It's a scar tissue structure. It's not an endocrine structure. So now you don't have progesterone, estrogen, and inhibin, because that was coming from the corpus luteum. So when those hormone levels go down, we have now released our negative feedback. Now there's no more hormones telling the hypothalamus and anterior pituitary to stop releasing hormones. So what are they going to do? They're going to start releasing hormones. And then you can't find your way back over here. Now the hypothalamus resumes GnRH release, and the whole lovely cycle will continue again. Now, what happens if fertilization does occur? So if the secondary oocyte, okay, so it got ovulated, and then it went through the uterine tubes. If it gets fertilized and it successfully implants into the uterine lining, the fertilized structure is called a preembryo, and it starts to release something called human chorionic gonadotropin, or HCG. HCG is a hormone that enters the mother's bloodstream, and it acts on the corpus luteum. So HCG stimulates the corpus luteum to continue on doing its job for just a little bit longer. So the corpus luteum will continue to release progesterone and estrogen, which is going to maintain and continue to build the uterine lining. So after about 3 months, the placenta will develop, and it starts producing its own hormones, at that point, then the corpus luteum, we don't need it anymore, and it can again regress and become a corpus albicans. But it can't do that until the placenta has kind of taken over its job. So absent of pregnancy, the corpus luteum will degenerate into the corpus albicans, hormone production stops, and then a new cycle will start again. If you get fertilization and you get implantation, that pre-embryo starts to release HCG. HCG will talk to the corpus luteum and say, hey, we still need you. So the corpus luteum will stick around for approximately the next 3 months. It will continue to release the hormones that are necessary to maintain that uterine lining. And then eventually the placenta will develop and take over its job as the kind of endocrine tissue at that point. Okay, so we are going to move on from all of this cycling for a quick second to discuss some other parts of the reproductive tract. So we have been focusing all of our time in the ovary. So now we're going to move into the uterine tube. Okay, so the uterine tubes, these are the fallopian tubes. They're sometimes called oviducts. They extend laterally from the sides of the uterus. So this area over here would be the uterus. And so extending laterally from them is the uterine tubes. And they're composed of a few different regions. So you have the infundibulum, which is this kind of free, it's almost like a funnel shape because it's wider down here, lateral margin of the uterine tube. It's got these finger-like structures right here. These are called fimbriae, and they kind of wave and kind of create this current. So that you can see there's not actually a direct connection between the ovary and the uterine tube. So the fimbriae create this sort of current and fluid, so when the oocyte gets released during ovulation, it pulls it into the infundibulum of the uterine tube. So then the next portion is called the ampulla. This is kind of the middle extended region. If fertilization of that oocyte is going to take place, it's going to happen within the ampulla of the uterine tube. Then you have the isthmus. Isthmus is extending medially towards the uterus. And then you can't see it here, but the uterine part is the part that actually opens up into the uterus. If you look at the histology of the uterine tubes, you've got the mucosa area in here. So this is going to be the lumen. The white space is going to be the lumen, or the open space of the uterine tubes. And then you've got the mucosa, you've got the muscularis layer in here, and then the serosa is on the outside. So you'll notice that the mucosa has all these inward projecting structures here that kind of encroach upon the space of the lumen. After ovulation happens, you have the cilia on the cells of the infundibulum and the ampulla, and they start to beat in the direction of the uterus. So it creates this kind of fluid current that can allow the oocyte to continue on in the direction of the uterus. So it's headed towards the uterus starts in the infundibulum, and then through the ampulla, and then the isthmus, and then gets to the uterus. The muscularis here is composed of smooth muscle, and then the serosa here is just kind of that external serous membrane covering. Okay, so we saw the ovary, we saw the uterine tube, and now we're going to look in the uterus. The uterus is a pear-shaped, it's a thick-walled muscular organ. It's located in the pelvic cavity, so it's pretty low. Functions of the uterus, so following fertilization, the pre-embryo is going to make contact with that uterine lining, and it's going to plant in the uterine wall. The uterus is then going to support and protect and nourish that embryo as it develops into a fetus, forming a vascular connection that later turns into the placenta. The uterus is going to be responsible for ejecting the fetus at birth by contracting its muscles. So you have oxytocin levels that will increase. Oxytocin promotes muscular contractions of the uterine wall, so it's essentially going to kind of squeeze it out. And then if the oocyte is not fertilized, the muscular wall of the uterus will contract and shed that lining as menstruation. if you get weakness in the pelvic floor muscles, so the uterus is kind of suspended. So you've got pelvic floor muscles that kind of help support it from the bottom end, and then you've got all these suspensory ligaments that help support it from the top end. If you get weakened pelvic floor muscles or weakening in those suspensory ligaments, it can cause a prolapsed uterus, which is basically where the uterus starts to sink. And if you look at where it's connected, it would sink into the vagina. So it's all interconnected. So here's the uterus. This bottom part of the uterus is the cervix, and it sits right at the superior top of the vaginal canal, which is right here. So if you can imagine these like suspensory ligaments that were essentially like hanging the uterus from, if those become weak or your pelvic floor muscles become weak, the whole uterus is going to sink down, and you can get some of the cervix down further in the vaginal canal where it wouldn't normally be. So that's a prolapsed uterus. There's 3 layers of the uterine wall. You've got the perimetrium, which is on the outside of it. The myometrium is the muscular middle layer. And then the endometrium is the inner layer of the uterine wall. Okay, so look at more about the anatomy of the uterus. It's broken down in a few different regions. So you've got the fundus, which is kind of this curved shape superior region of the uterus. The body is the major portion of the uterus. It's that made up of a thick muscular wall. The isthmus is where it starts to kind of narrow down as you get towards the cervix. And then this area right here is going to be the cervix. So it's the narrow, most inferior portion of the uterus that's going to project slightly into the vaginal canal here. So here's the vaginal canal, fundus, body, isthmus, cervix, vaginal canal. So a closer look just at the cervix again. The cervix is just that inferior portion of the uterus that kind of connects it to the vagina. The cervix has this opening at the top of it. This is called the internal os. It's the superior opening. Then you have the cervical canal, and then at the bottom you have the external os that opens into the vagina. In the cervix, you've got a bunch of glands that release mucin that, of course, create mucus. And then that mucus serves as a physical barrier to keep anything that might have made its way into the vagina from getting up into the uterus. Now, that mucus plug does thin considerably around ovulation. So actually closer to ovulation, you actually get a little bit of an opening of the external os because it's normally fairly closed. That kind of opens up, and then you get a thinning of the mucus plug, and it actually changes a little bit in composition to help facilitate the entry of sperm. So the cervix kind of adjusts itself a little bit during ovulation time to help encourage sperm to move from the vagina into the uterus. There's a clinical view on cervical cancer. Cervical cancer is one of the most common malignancies in the female reproductive system. One of the #1 risk factors of it is the presence of the human papillomavirus. Having said that, there's a variety of different strains of the human papillomavirus. Some of them lead to genital warts, some of them do not, some of them increase cervical cancer, some of them do not. So it's kind of it's a definite link, but there's a lot more specifics that kind of go into it. The best way to test for this is to do a pap smear, where they basically take some of the cells off of the cervix and just kind of look at them under the microscope. And you can kind of see in the image, you know, the normal cells that should present themselves, and then they can tell if the cells are showing any kind of abnormality or abnormal growth or anything. It's just kind of a way to get a quick assessment, because then if you do see abnormal growth, then you'd want to go in and actually get a tissue sample and kind of look at it that way. So this one talks about a tubal pregnancy, which is a form of ectopic pregnancy. So An ectopic pregnancy is any time that the fertilized oocyte implants itself anywhere other than the endometrial layer of the uterine wall. So a tubal pregnancy specifically is when it implants in the uterine tube. Okay, so this guy should be implanted over here. He's in the uterine tube. For sure, the uterine tube is not able to accommodate an embryo or a fetus. So unfortunately, if a tubal pregnancy occurs, there's really no way to save the embryo. They have to remove it. If it doesn't get removed, eventually it will cause a rupture of the uterine tube, and that can result in massive hemorrhaging on the mother and can be life-threatening. So at this point, there's no way to relocate or anything like that. It just has to be removed. Endometriosis is a condition where part of the endometrium, or that inner layer of the uterine wall, gets displaced onto other organs in the abdominal pelvic cavity. This can cause a lot of pain for the woman because what happens is that endometrial tissue, that responds to estrogen and progesterone. So as the normal hormones fluctuate throughout the cycle, that tissue is going to build and grow just like it would if it were in the uterus. But since it's not in the uterus, it doesn't have a way of getting out of the body as would normally happen in menstruation. So it can be painful, it can cause scarring. So the treatment for this is just to kind of go in and try to remove some of that ectopic endometrial tissue. So continuing to move downward, again, we've been through the ovaries, the uterine tubes, the uterus, the cervix. So we've made our way into the vagina. So the vagina is a thick-walled canal that forms the inferior-most region of the female reproductive tract. It connects the uterus with the outside of the body, and its functions are to act as the birth canal, the copulatory organ of the female, and then the passageway for that menstrual fluid. Vaginal epithelial cells produce a secretion that is fairly acidic, and that helps to prevent bacterial and other pathogenic growth from growing within the vagina. Okay, so the menstrual cycle and menstruation. So I talked about how there's changes going on in the ovary during the ovarian cycle. There's changes going on in the uterus at the same time, and also as a result of the same hormones by and large. But very different, it looks very differently for the two organs. So the menstrual cycle happens as a result of those hormonally induced cyclical changes, and it leads to changes in the endometrial lining. There's three main phases here. There's the menstrual phase, the proliferative phase, and the secretory phase. Menstrual cycle is again represented as a 28-day cycle, but of course there's a lot of variation in that. Okay, so the menstrual phase occurs from day 1 to day 5. This is the actual sloughing off of the uterine layer. So this is the period of menstrual bleeding. The proliferative phase follows that. It goes from about day 6 to day 14, where you get the initial development of that new functional layer of the endometrium. So we've just sloughed off the lining that was there from before. So now through days 6 through 14, we're going to start to build a new functional layer. This overlaps the time of follicle growth and estrogen secretion by the ovary. So if you can picture both the uterus and the ovary in your head, in the ovary, you're getting development of that follicle and the release of estrogen, and that's causing the formation of a new layer within the uterus. The secretory phase happens about day 15 to 28. During the secretory phase, you have increased progesterone secretion that's coming from the corpus luteum, and that results in higher vascularization and development of the uterine glands. So we've built the tissue lining during the proliferative phase, then ovulation happened around day 14, and then the corpus luteum took over in the ovary, so now we get a large amount of progesterone, and so we start to vascularize. So secretory phase, we're vascularizing that layer. We're putting in a lot of new blood vessels, which is going to be necessary in case the embryo comes along and implants. The corpus luteum would degenerate and progesterone levels drop if no fertilization takes place. And so without that those levels of progesterone, then the functional layer begins to slough off again, and we will start back up with the new menstrual phase of the next cycle. So I love, love, love this diagram. And I like it because there's a lot going on. And this kind of puts it all in one nice, pretty picture for you. So this top panel up here is showing you what's going on in the ovaries. Okay? This is showing you what's going on with the hormone levels. And this is showing you what's going on in the uterus. And all of this is being tracked from day 0 through day 28. So 28-day cycle, what's happening in the ovaries, what's happening with the hormones, what's happening in the uterus. So I'll try to kind of walk you through it. So just start kind of in the uterus, we're sloughing off. Day 0 or day 1, we're always start to slough off the uterine lining. So this is menstruation happening right here. Okay, we start to get a release of FSH. We know that that came from because GnRH and the hypothalamus stimulated FSH from the anterior pituitary. So we see that go up. So what that does is it stimulates some of these primordial follicles in the ovary to start developing. Okay, so they start developing. Do you remember what they released when they start developing? One of the things they release is estrogen. So notice that as this follicle is developing, you see estrogen start to go up, okay? Because all of these cells surrounding the oocyte start to release estrogen, so you see the levels of estrogen go up. As the levels of estrogen go up, what also goes up? The uterine lining. It starts to respond to that estrogen, and it builds and it builds and it builds. Notice the FSH levels start to go down. Why would that happen? What else was being released from the follicle? Inhibin. And inhibin and low levels of estrogen cause that FSH to go down. Okay. So as we increase estrogen, it also promotes the continued development of that follicle. So it's kind of stimulating its own self to continue to grow. So it grows bigger and bigger, and we get more and more estrogen. Now this is where that weird paradox happened. Low levels of estrogen prevented the release of FSH and LH. But as we get to this really large vesicle here, it starts to release so much estrogen that it has a positive feedback or a stimulatory effect on luteinizing hormone. So luteinizing hormone, you see if you come back here, it had a little rise in the beginning and then it dipped back down and then it just kind of minded its own business. It's the pink line right here. But as estrogen gets so high, you get this really quick surge. It goes way up and it comes way down. And do we remember what that surge did? The luteinizing hormone surge caused this rapid influx of fluid in this vesicle, and so much fluid built up that it caused it to rupture. And that's when ovulation happens. So right immediately after the LH surge, you get ovulation. Okay, so here's ovulation. So you see a decrease in estrogen right after ovulation. It's going to go all the way down. And why? Because we lost some of those follicular cells that were releasing estrogen. But what do we see start to go up? Progesterone. Progesterone is starting to come up. Why is progesterone coming up? Because under the influence of luteinizing hormone, the remnants of this vesicular follicle became the corpus luteum. And the corpus luteum, it does release estrogen and inhibin as well, but it releases a lot of progesterone. So this is all the corpus luteum right here, releasing all this progesterone. It's releasing estrogen. And what is it doing to the uterine lining? It's vascularizing it. Estrogen continues to build the uterine lining, and progesterone vascularizes it. It provides a lot of new blood vessels. Okay, so let's say no pregnancy occurs. Oh, before that, let me go back and say the estrogen and the progesterone and the inhibin that are coming from the corpus luteum are having negative feedback relationships with luteinizing hormone and FSH. So FSH is green and LH is pink. Notice that those are very low down here. And they are low because of the negative feedback of estrogen, progesterone, and inhibin, which is not shown here. Okay, so now let's assume no pregnancy occurred. So we don't get any signal from the uterus telling the corpus luteum to carry on, because normally if a pregnancy happened, HCG would start being produced and it would tell the corpus luteum to keep hanging around for a while longer. But that doesn't happen. So the corpus luteum is going to degenerate into a corpus albicans. That is a scar tissue structure and it does not release any hormones. So as the corpus luteum becomes a corpus albicans, look what happens to progesterone. Down it goes. Look what happens to estrogen. Down it goes. Now we have no hormones to maintain the thick uterine lining. So we come around here to the new cycle and out it comes. Without hormones there to maintain it, it's going to slough off, and that's at which point you would start a new menstrual cycle. So backtracking just a little bit, if you can kind of tell at the very end of this graph, so LH and FSH are really low. Do you see them start to uptick just a little at the very end? That's because all of the negative feedback that was happening as a result of the corpus luteum hormones, so progesterone, estrogen, and inhibin, when the corpus luteum regresses into a corpus albicans, all those hormones are gone. So we have no inhibitory feedback coming to the brain, which means FSH and LH are going to go back up. And we are going to start back over here with a new cycle. So hopefully that was entertaining for y'all. But that is why I like this diagram, because you can see the whole picture in one nice diagram, and you can kind of see how it's all interrelated. Just some of the hormones that we've talked about: gonadotropin-releasing hormone, follicle-stimulating hormone, luteinizing hormone, estrogen, progesterone, inhibin, where these hormones are coming from, and some of their main effects within the cycles. Okay, we have finally made our way to the external genitalia. We are out of all of the internal structures. Okay, so the external reproductive organs of the female are called the vulva. We like to call it the vagina, and I don't know why we do that, because the vagina refers to the internal canal. The external genitalia is the vulva. The mons pubis is this layer here. It's a layer of skin and connective tissue just immediately anterior to the pubic symphysis, which is a bony structure. The labia majora are the paired folds of skin and connective tissue on the outer edge, and then the labia minora are the inner skin folds. Labia majora and the mons pubis are typically the areas that have pubic hair. Labia minora and everything internal to that does not. The area between the labia minora is called the vestibule. So everything in this green circle is referred to as the vestibule, or the vestibule of the vagina. It includes both of the openings, the urethral opening, which is the opening for urine, and then the vaginal opening, or the vaginal orifice, which is the opening for birth, copulation, and menstrual fluid. The clitoris is a small erectile body at the anterior region of the labia minora, so up here. This is a homologous structure to the penis of the male. So homologous means that it developed from the same kind of tissue origin, tissue type in both sexes. So at our very early beginnings, we kind of look the same in terms of sexual organs, but they, under the influence of hormones and other factors, you kind of, in genetics, hormones and genetics and other factors, you kind of choose a pathway and you either become male or female in terms of the anatomy. So the penis and the clitoris are from the same kind of origin. So both are made up of erectile tissues. And I don't know if we go into it so much here. If we do, I'll point it out. But actually, the clitoris is a much larger structure. It goes kind of further up, and then it branches deep down kind of on either side. You can't ever see it if you're looking because it's more of an internal structure, but there's a lot more of that erectile tissue that's on the inside that you can't see from just the external genitalia. Okay, so there's a lot of specialized nerves in the clitoris that provides sexual pleasure and sensation. So actually the clitoris serves no function other than sexual pleasure. And then you've got the prepuce, which is an external fold of the labia minora that forms a partial covering over the clitoris. So it kind of, if you follow the labia minora up, it's kind of hard in this picture because it's kind of too small, but it forms a covering over the actual clitoris itself. Okay, the mammary gland or the breast. Each mammary gland or breast is located in the anterior thoracic wall. I'm pretty sure everybody knows where the breasts are located, but just in case you didn't. And it's an exocrine gland. So remember, endocrine, it releases a substance to the blood. Exocrine releases it anywhere else. Now, sometimes that means it releases it into the stomach or the oral cavity. In this case, it's releasing it outside of the body so that it can provide nutrition to our young. So the secretory product here is going to be breast milk coming from the glands. So the nipple is the cylindrical projection that's right in the center of the breast. It has a bunch of tiny openings. That's your excretory ducts for the transportation of the breast milk. And then the areola is the pigmented skin that surrounds the nipple. The surface of the areola is often uneven because you've got a bunch of sebaceous glands called areolar glands that lie just underneath the surface. And though I don't know that anybody knows the reason for this, the skin or the color of the areola usually darkens after a woman has given birth. Okay, clinical view, breast cancer. Breast cancer affects 1 in every 8 women. It can also occur in men. Men can get breast cancer as well. Some of the well-documented risk factors are obesity, nulliparity. That means never having had a child. So I don't think they know the science behind it yet, but somehow even having given birth just one time in your life helps offer a little bit of protection against breast cancer. Longer reproductive span. That means if you were to maybe start menstruation at a younger age, let's say you started menstruation at like 9, and then you hit menopause at 58. So if you were exposed to those cyclical hormone changes for a longer period of time than the average, that also increases your risk for breast cancer. And then there's genetic factors. So the BRCA genes are kind of well known to be a very high risk factor for breast cancer. So a lot of times people can get tested for that. Kind of the best recommendation is to get mammograms to help you get early detection. Mammography, I don't remember, I guess it's still 40 for the average recommendation. But anyways, it's an imaging technique to see if there's in the beginnings of any kind of tumor there, and that way they can get a early diagnosis, because cancer is always easier to treat if you can catch it early.